Good morning. My name is Kevin Kirkpatrick. This is the Healthcare People podcast. Today, I am joined by Dr. Laura O'Connor, the provincial lead for family medicine in the beautiful province of Prince Edward Island, and Mary Laura Cody, who is the something in medical affairs. I don't even know your title after all this time, right?
Manager of Physician Services, Family
Manage,
Medicine.
wow, that's a big one too. Manager of Physician Services, Family Medicine. So basically, you make sure the doctors do what they need to do and keep them out of trouble, right? So I'm a pretty informal guy, so this will just be kind of a conversation. Um, I, I've been working with you guys for about 6 or 7 months, and one of the things I think that is kind of unique is family medicine on the island, um, and the benefits to the patients, the benefits to the physicians themselves. So, Dr. O'Connor, I wonder if you could just tell us a bit about your role and what you do, and we'll start there.
Sounds good. Thanks, Kevin. So I'm the medical director for family medicine and focused practice within medical affairs at Health PEI. So PEI is kind of unique. We have a health authority that covers the whole island and just the one health authority. So it's kind of all connected. So I'm within the medical leadership structure there. And I work with Mary Laura, who's the manager, make sure all the family doctors on PEI get paid and have contracts and all that good stuff. Yeah, so that's kind of my role. I also work 30% clinical in a patient medical home here in Charlottetown with my own panel of patients, and great locum coverage for when I'm not there. So
nice. What
another hat.
You mentioned patient medical home. What does that entail?
Patient medical home is a model developed and endorsed by the College of Family Physicians of Canada. And most family physicians watching this would probably be somewhat familiar with the concept, but it's team-based care.
Okay. In
a nutshell. So it's a place where a patient can go and get the care they need, not necessarily just going to a doctor's office and seeing a doctor every time, but just being matched with a healthcare provider that's got the scope of practice that they need.
Okay.
And yeah, so that team with a family physician works with, RNs, nurse practitioners, physio, LPNs, medical secretaries, social workers, psychology, pharmacy, like any number of health providers as a team, and that makes the home.
Nice. Given the team-based care, do you have an idea of what the average roster size or panel size for a family physician in PEI is?
It's a good question. Our earliest homes that have formed are just kind of coming up on the 2-year mark.
Okay.
So we haven't quite figured out the added capacity of a patient medical home and what that might add to a physician's capacity load.
Okay.
We have our kind of current policy that we're working on, or that we're working from, is rooted back in the days of solo practice. So that is sort of a flexible number. It ranges from 1,200 to 1,600 for a full-time family physician, depending on what else they're doing. So we tend to base their panel on their work in that panel practice. So if they're doing a day a week of women's health, or they're doing, they do hospital care for their patients, we sort of deduct that from their clinic FTE or full-time equivalent, and base their panel on that. Nice. But I should say we're working right now on what does a patient medical home panel look like? So we're actively kind of developing that policy, and we expect it within the next couple of months.
Excellent. So talk to you. So one of the things that Mary Laura talked to me about beforehand was locum coverage and stuff like that. And I understand there are a team of physicians that are focused on providing locum coverage, because I know some of the other communities that I've worked with in other provinces, the physicians struggle to take time off, right? And because it's so competitive for locums now, that it's hard to find. So could you talk a bit about that?
Sure. And PEI was in that situation not too long ago. Like, I've been 10 years in practice, and my first 2 weeks off was 5 years into practice.
Wow.
And that's when I happened to get a locum, and it was a graduating resident. And so it used to be kind of few and far between that we'd actually get backfill. So within the last couple of years, I'm going to forget the exact date. I think our first hire was in November 2022. So kind of year and a half. We had newer grads coming out of residency and saying, I don't really want to take on a panel. I just want to shop around. And, this is a common story for new grads out of family medicine. But we decided, we always have a need for backfill. We always have a need for locums. And where most of the family physicians on PEI are either salaried or contract, so alternate payment modality rather than fee for service, like they actually have, our salaried physicians have vacation as a benefit, and they have 2 weeks of CME time as a benefit. So, on one hand, we're saying, here's all this time you have potentially to take off, you have sick time, but yet we know they're having trouble taking it because they don't have backfill, and they're coming back from vacation to a mountain of work. It's a tale as old as time for family doctors. So we said, well, why don't we hire these people? Why don't we salary them? And why don't we get them to join the fold and we schedule them? We know there's more than enough work for these positions. So we're up to 2.4 FTEs of physician relief positions. We have a few others that are slightly different. I guess their job description is a little bit different, but we also have a couple of locums, like true locums, that we've got in our fold. And we have a central scheduler, and we take dates from doctors, and we really just try to pair them and match them with a relief position of some kind. So I think that's super novel that we did that, and the physicians are letting us know that it's amazing. They're really, really pleased. Yeah.
Well, and it's, it allows you to focus on what new physicians want, as at the same time as providing a retention tool for the physicians that you have, right? So I think that's key and stuff like that, right? So, and it's interesting, you touch base on the salary piece and the different compensation models. And I found that, understanding what you're getting paid as a physician is often, like a sidebar conversation, right? Because, we don't, in Ontario, where I'm based, we don't have salaries, right? Everything's pretty much fee for service or FO for family medicine. And even the FO, it's dependent on roster size and access bonuses and everything like that. So, it's been interesting to talk to physicians about the notion of this is what the salary is. And especially young physicians, like I try and talk to them about the notion of a pension. Like, can you imagine what it's going to be like paying into a pension for 30 years as a physician?
Yeah, so I will say we don't have pensions here per se, but we have RSP matching.
Okay.
So
sorry.
Not to say we never would, but
we'll figure out how to edit that out later. Just kidding.
Oh, guys. That's fine. It's fine. We do have RSP matching though as a benefit, which is pretty sweet. So
yeah. You mean, and it's rare, right? Like you have to be an employee of a hospital to get anything like that in Ontario. So
yeah.
Oh, interesting. So what does a day in a family physician look like in PEI?
So a fair number of us do hospital work.
Okay.
So in addition to your clinic practice with your panel patients, I'm going to struggle with this a little because there's so many varieties of what people can do here. But I'll use my own example. So for the majority of my career, it would either be my hospital week or my clinic week. So we would do sort of a hospitalist style rotation. So my week might be entirely taking care of general medicine patients at the Queen Elizabeth Hospital, doing call for our group. So this is maybe a list of, say, 15 to 22 patients. So that's always pretty fun. And then my clinic weeks would be, showing up, seeing patients 8:30 till noon, 1 to 3:30. And then the time outside of that doing all the other trappings, so charting and sending referral notes and receiving results, talking to colleagues. And in the last year and a half that I've been part of a medical home, there's a fair bit of time that's just connecting with an RN who's seen a patient for their hypertension and is looking, knows that they're not to target with their readings and we need to escalate medical therapy. So we're talking about a medication change or talking to a pharmacist who is trying to deprescribe a patient from their sleep aid, and the changes that might be associated with that. So signing off on a dose reduction prescription, chatting about changes after a medication review or something like that for an elderly patient, chatting with a physio about somebody who might need to go on to imaging or something like that. They've been managing the sore shoulder, but now they're thinking there's an indication for a shoulder x-ray or something. So
Okay.
there's a lot of that collaboration as well.
So given that you're paid a salary, this is purely out of curiosity. How much of the time that you're paid for is clinical versus clinic administration, not your medical director administration?
Right. So for a full clinical day, like so say an 8-hour day, I would spend, I'm just trying to do the math on it, 5.5 to 6 hours seeing patients.
Okay.
And 2 to 3 hours, there's always some days that run over, but 2 to 3 hours doing paperwork and administrative tasks.
Yeah, because I do think one of the big complaints from a lot of family physicians, and this is more an Ontario thing, and I don't want to make everything about Ontario, but they're not, in a fee-for-service model, you're not paid for paperwork, right? So you've got all of that extra time. And I've heard the OMA say it in Ontario, say it's as high as 19 hours a week, right? So, that alone would be like, I think you should move to PEI, right? Like if you can alleviate 19 hours of unpaid work from that, then, and I think the thing I noticed about the visits that I've had over the last 6 months to PEI, the collaborative communication that I've seen is really high. Like I've talked to internists that, know who the family physicians are and have talked to the family physicians, and it's not a hierarchy where you're, faxing something to an office hoping to get a response, right? So, it's quite interesting and stuff like that. So how did you land in PEI?
So I grew up here.
Okay.
That's often a story you hear from us, but I grew up in the eastern end of the island in Surrey.
Okay.
And I studied sciences in Halifax at Dalhousie and worked in research for a couple of years, decided I probably was more fit for medicine, and applied a couple of times. I got into Memorial University
Nice.
for my undergraduate medicine. And then just life circumstances, I wanted to come back to PEI. My family is here, my parents, and I really love PEI. I don't know, it's something about the island. I just feel like very comfortable here. So I decided to come back. I did my residency program here because Dalhousie has a residency sort of satellite site. So that was super fortunate. And that just led to a great career here. So
if somebody comes and opens up a practice in PEI and they want to do teaching, is there an opportunity for them to do that in PEI?
Yeah. So most of my colleagues and I were appointed as clinical faculty for Memorial and Dalhousie.
Okay.
Where we have lots of students coming for rotations, like everywhere from first and second year students coming for their black bag, like dip their toe into clinical medicine, to core rotations. Like we have clinical clerks doing core rotations here with us. And then the family medicine program, the last 2 years, I've had a resident with me, which is awesome. And so there's lots of opportunity there. We have 10 residents in the program at any given time, 5 per year, but that's going up to 7 per year.
Nice.
Laura will nod if I'm correct. Yeah, there you go.
Yeah, and it's interesting because I found that having residents and exposure to medical, so it's almost like a tiered effect, right? If you have medical students, it's going to lead to more residents, and more residents is going to lead to more recruiting, right? And people want to be in an environment that's constantly developing and stuff like that, right? So one of the other things you mentioned was like 2 weeks of CME. Like that's an amazing benefit as well, right? Because, retention is key, right? And I think, I mean, which is funny coming from a recruiting guy, but how you retain will dictate how well you can recruit, right? And people know people, and they will follow their friends, and they'll follow their colleagues, or they'll hear about how great something is, right? And I laugh because I talked to a dermatologist this morning, and he's in the UK. He was referred to me by one of the UK physicians that I'm talking to about PEI. Right. So the more you talk to people, and they experience good things, the more that other people become interested in it. Right. And the thing that I love is like PCH and QEH. I mean, they're not really that, by island standards, they're far apart, but by Ontario standards, it's like my commute to work used to be further, right?
Yeah, they're
So,
pretty close. Yeah.
Compared to Toronto, right? My commute to Humber River Hospital was an hour and a half. I could go to PCH from QEH and back in the same time frame, right? And even there's Tim Hortons on the way, so I could stop like several
Multiple
times
Tim Hortons on the way.
and still
a few roundabouts.
Be there, right? Yeah, there are a few, and then the Cavendish Farms factory, or like that. I don't know. I mean, this is embarrassing to say, but I pulled over and rolled down my window to smell it.
Yeah, that's one of the benefits of the trip to Summerside for me, is the smell of French fries like wafting over you as you drive through.
And it was like 8 o'clock in the morning. I'm like, I've never wanted French fries at 8 o'clock in the morning before, right? What is the specialist support like for family physicians in PEI?
It varies. We're a small group, and like the whole province sort of is a small net number of physicians. So we can have a group of 2 or 3 urologists, or 2 or 3, help me out, plastic surgeons or something like that. And at times, just depending on who's retiring and who's coming and going, you can have crunch periods.
Right.
For any of the given specialties. I think right now we're having some struggles with internal medicine is probably the biggest one. And so we're looking to like really bolster our internal medicine services, because it's just so key for everything from, bread and butter internal medicine clinic stuff right up to critical care. So that's got a lot of focus on it right now.
Right.
I think a big thing to say about the specialist support on PEI is that there's not many subspecialists.
Right.
Like we have a bunch of general internal medicine people who are like super versatile and can kind of answer your question on pretty well anything, which I think is awesome. I haven't spent a lot of time in the big urban settings, but we're not sending somebody for like a left earlobe consult or whatever. It's not really, really narrow scope, and you're wondering like, who do I call about this? You just sort of call, and people will take your case. And it does 2 things. Like, one is that you're well supported by a bunch of people. 2, as a family physician, your scope ends up being fairly broad. Like there's not, just, okay, this issue I'm going to refer here. There's not always a place that's that perfect referral. So you end up doing a lot of footwork yourself,
right,
trying to figure things out. We have supports like Virtual Hallway. That's a relatively newer service, where I gather it's similar to eConsult in Ontario, where you can sort of schedule a time to chat with a physician. Just, you have a clinical question. You don't necessarily want to refer the patient, but you're a little stuck at your level of next steps in management or investigation. So that's been really nice.
Yeah, and you guys have relationships with like Dalhousie and other provinces too, right? Like it's an interesting thing that I've noticed with like even with the Atlantic Registry, right? Like the borders on the East Coast seem to be a bit less than the borders in other parts of the country, right?
Yeah, like you can imagine, we're not doing cardiac caths on PEI. We have a population of 170,000. So just, as much heart disease as we might have, it's not necessarily enough to keep a cadre of surgeons up to skill,
Yeah.
there's just not enough. So if we had one cardiologist or interventional cardiologist doing it full time, that's one thing, but you can't just have one interventional cardiologist. So yeah, we have relationships with Halifax, St. John, Moncton, for a lot of our services.
Nice.
And what I'll just add, Kevin, kind of on that point is, I think for new physicians that are coming in, because we're really small, well-connected, both with specialists and family medicine, those new physicians that are not as familiar with who someone is, like in terms of a specialist or a fellow family physician, they're really well supported, because all it means is picking up a phone or walking down the hallway in a patient medical home setting to kind of ask, like, who do I send this to? And just speaking on the Atlantic Registry and the Atlantic provinces as a whole, because we're small, the physician community, oftentimes someone has a classmate that they went to med school with, or they did residency with, that's practicing in Halifax, or they're practicing in the Valley in Nova Scotia. And so it's very easy to pick up the phone and say, can I send this patient to you? Or what are your thoughts on this? Even if it's not an actual consult, but just, can I run this by you and I have your perspective?
Yeah, and I think that's an interesting thing about what I've noticed in PEI is that a lot of it, like it's got big city amenities within the confines of a smaller town, right? Like I've stayed right downtown, and there's a ton of different restaurants and places to go and stuff like that. I could start a list that I've got on my phone of places to go when I'm there. But yet the sense of welcoming, like I didn't go anywhere without talking to people, right? I had some lady sit with me at the coffee shop because I was by myself and just say hello and start talking to me, right? And I thought that was cool, right? It's people say hello to you at the gas station. Not that I use much gas driving around, so note to self, you can spend less gas if you live in PEI. And then it's something that I'd like that I'm curious about is that in a conversation with Dr. McNally, she mentioned that obviously 40% of your hires come from Dow. Makes sense, giving the teaching piece, but you also get a lot from Newfoundland and Ontario even, and then some international as well. So it's interesting to see that it's a big like it's a lifestyle thing, right? Like people are coming for a lifestyle and not having to sacrifice their career because of the fact that you're going to get to continue to grow your career at the same time as affording a house, right?
Yeah, totally. I when I go to a bigger city, I find like there's an expectation that people dress a certain way and act a certain way, and like I feel like there's a bit more of like a keeping up with the Joneses, but on PEI it's just super casual. Like you can live wherever you want. You don't have to be in some certain neighborhood.
Yeah.
You can drive a beater car. Like there's no expectation that you have to be in this certain class or whatever. It's just very accessible. Like, well, especially growing up in a small town, like if you're in Surrey or Montague or Kensington or something, everyone kind of knows you. You're very visible. So it's just I don't know. It just seems like much lower key than a bigger city.
Yeah, and it's it's interesting because I think sometimes that can scare people off, but I also think that the structure, and this, to go back to the medical care homes and go back to the the 2.4 FTE doing locum support, like I think you've built a really good structure to support the physicians at the same time as not being in a big city, right? Like it's not like there are some regions where you're the only physician. Like last year I had a community ask me to help them recruit a physician, and it was going to be the only physician in the entire community. And it's like I told him, I don't think I can do it because it's not what, like, it's going to be a rare physician that's going to want to go and be the only physician in a community, right? But
Yeah.
some people like the ability to have a support structure around them, but also have that quiet, quiet, low cost of living, right? Like I remember sitting with one of the internists, and he's showing me farms on his phone that were up for sale, and they were like half the price of my house here in Ontario, right? Now, needless to say, I'm not allowed to sell my house and buy it, but something about can't move your children halfway across the country on a whim, right? It's not a whim. I said, I know people in PEI. It's like moving somewhere where we know people. Way to go, right? But no, not happening. So, all right. Well, listen, is there anything that you would say to another physician that you meet at a conference on why they should come to PEI?
Yeah, I don't want to make this too long or too deep, but I think there's a culture change happening on PEI since probably I've seen it since maybe 2018, 2019, where the level of sort of respect and acceptance between physicians, the medical society, the health authority, there's a really good working relationship there. And our physician leadership structure has really just expanded. There was a big project to kind of reform it. We have a new set of bylaws, and you see a lot of physician engagement, and it just feels really good. Like you're able to, especially if you're in a formal administrative position, but you're able to affect change, you're able to contribute and not just feel like you gotta, complain about the system. You can actually get in there and try to add ideas and make things happen. I see that with the physician relief program. Like that's just an idea that physicians had that we made happen. So yeah, we're renegotiating our contract right now, actually. So I'm glad we didn't spend too much time talking with the ins and outs of our contract, because ideally in the next few months we're going to have a new agreement. But for this second round, we're in interest-based negotiations. So interest-based negotiations, if nobody knows about that, is you're all on the same side of the table. It's not, us versus them. It's what do we need to happen here? What do physicians need? What does the system need?
Yeah.
How do we build this agreement to make as many people happy as possible? And so I think the fact that we were through one round of interest-based negotiations 5 years ago and now a second one, that's testament to the strength of relationships between, what used to be probably quite siloed groups.
Nice.
Or even like, groups that had a bit of contentiousness. So I think that's something we have on PEI that I'm not seeing at other places.
Yeah, and it's interesting because I think the something that I talk about a lot online and stuff is about impacting the actual work of the clinicians, right? Because we keep asking for more and more and more from clinicians, and I think we've gotten to the point where in some jurisdictions we're burning the physicians out, right? But if you can say that 7 hours out of 8.5 a day is patient care, and then you've got time to focus on follow-ups, to focus on charting, to focus on the things that aren't necessarily patient focused, patient in front of a patient, but are patient focused. I think that's a huge benefit to the physician, but I also think it's a huge benefit to the patient, that the likelihood that you are going to have a conversation with the specialist beyond a referral form is massive, right? So and then the thing I've found is I've met, I don't know, dozens of physicians in PEI, and the collaboration and the communication and stuff that I hear amongst each other is quite interesting. And quite impressive from that standpoint. So I thank you both for your time. This will be we've been recording this, and we'll share it on LinkedIn and stuff like that, and then hopefully we will share, we will have shared enough to let people understand why PEI is different and why it's a great place to practice, and go from there.
Awesome. Thanks so much for the opportunity, Kevin.
And my pleasure. You did great. Right? So, I'll buy a coffee the next time I'm in PEI.
Sounds great. I'll take it black.
Oh, even easier. Then I can remember that, right? So, all right, guys. Have a great day. All the best.
Thanks. You too.
Bye.
Bye.